This talk is understanding your kidney function after organ transplant, and it's not specific to kidney. This could be kidneys for any organ transplant or even as you're developing kidney issues. But really, the kidneys, they just don't get no respect, and that's my entire life's work. Um, so whether you are living with a child who's had a heart transplant or a lung transplant or a kidney or a liver transplant, the reality is that there is a substantial number of these children that as they grow up, they may require a kidney transplant. This is data on adults showing when you look at from the time of their organ transplant to 10 years later, how many of adults who have received, say, a liver transplant, 20%, 25% of people who have had a liver transplant, 10 years after the liver transplant, need a kidney transplant or have kidney damage. This data here is children. So this is the number of years following a solid organ transplant, and these are the different organs transplanted. So children's organs are healthier than adults, so it takes longer. But for children as well, if they are living long enough, they may develop the need for a kidney transplant after their liver or heart or lung transplant. Well, why is that? Well, we know that the reason that your child is sick with a heart transplant or liver transplant is they are ill. And often the drugs or the intensive care experience or sepsis or the actual process of the organ transplant can cause damage, which is acute kidney injury. But in a healthy person with a healthy kidneys, often that damage can be fully recovered, and very few people develop permanent kidney failure. But the problem with an organ transplant patient is in addition to whatever causes the kidney injury, because they're immunosuppressed, they are at risk for infection and drug toxicity. And with that infections, they might have diarrhea and low blood pressures and things like that. So that acute kidney injury is repeated again and again and again on top of drugs, which make it harder for the kidney to recover. So there's more people living with any kind of organ transplant or chronic illness who may develop kidney failure. So let's talk about the kidneys. The kidneys are protected and they're deep in the back of the body, right up against the back, protected by the big, strong muscles of the back here and the ribs. But as you get closer to the kidneys, and you start looking at them with a microscope, you find that the kidneys are built of a whole bunch of little filters. And the actual filtering point is called the glomerulus. And how much the glomerulus filters is the most reliable indicator of how good your kidney function is. Well, some of the things that can hurt your kidneys are the doses of Prograf and cyclosporin that your children take. So this is a picture of the glomerulus of a kidney and the blood vessel pumping blood into that glomerulus. And this is obviously an animal. And then right after a dose of cyclosporin, see how that blood vessel has narrowed? Cyclosporin and Prograf cause the blood vessels in the kidney to develop temporary spasms. And that occurs again and again with every dose of medication. So I want you to keep taking your immunosuppressive medication, don't get me wrong, but it's a dual-edged sword. And that's why the doctors spend so much time checking those levels. This is a kidney biopsy of a person who had a heart transplant at the time of their heart transplant. And this is a kidney biopsy done a few years later. And the blue is scarring, showing all the scarring that's developed in this. And this is the same kidney that was biopsied a few years after their heart transplant. Other things like infections, like something called BK virus, which can happen in people who have transplants with lung or heart or liver transplants. High blood pressure. So high blood pressure can damage the kidney, can damage the heart, and that damage makes your blood pressure go even higher. And it's a vicious circle. New onset diabetes. Many of the immunosuppressive drugs that we need to provide our patients can cause new onset diabetes. Also, if a person is of African American or Hispanic genetic heritage, that's an increased risk. Or if you're obese, or if you have pre-existing hepatitis C, or you need a lot of steroids. So there's a lot of reasons to develop diabetes. So I've now explained why you need to think about the kidneys, even if you didn't think that the kidneys were an issue if your child has had a heart transplant or a liver transplant. So let's talk about what's the best way to understand how your kidneys are working. So your doctor checks your child's kidney function by checking the serum creatinine. And the serum creatinine is a simple, easy blood test that's routinely done in the metabolic panel. And I'm going to show you how I look at my serum creatinine. So I have taken a screenshot of my iPhone, and I've gone onto the Stanford Healthcare website for patients. And I go to lab test results. I pull up a metabolic panel, and I go into the metabolic panel, and then there's sodium and potassium chloride. But when I scroll down, there's the creatinine. Now, in my situation, my creatinine is 1.3. It also gives me an estimate of my GFR, the percentage kidney function, with a normal being above 90 or 100%. And my estimated GFR is 58, based on the serum creatinine and a bunch of assumptions it makes about me, my sex, my age. But look at this. If I was black, if I was African American, it says my GFR is different, actually better. So this is because when they did the testing that developed these equations, the African American patients who participated tended to be heavier and have more muscle than the Caucasian patients. So there's a difference. But this is really controversial. So people are considering taking out the African American designation in the GFR testing. So just be aware that's changing. Um, because the assumptions that were made for African American patients versus Caucasian patients aren't necessarily valid. So that's a real controversy. But anyway, this gives you an idea. Now, creatinine is made by muscle. So this little girl here, she might have a normal creatinine for her of 0.5. But on a muscular man, oh, say our previous governor of the state of California, what would you guess his creatinine would be? And remember, my creatinine is 1.3. Well, I would guess, based on his muscle bulk, that his creatinine might be 2.3. Now, if I had a blood test of 2.3, I'd be talking to my doctor about my kidney failure. Now, here, a bit later on, when he was famous in the movies, but not quite as buff, maybe his creatinine was 1.9. But here, after he's governor for a while, his creatinine is probably more close to mine. And that all makes sense because muscle makes creatinine. So the creatinine by itself is only a piece of the puzzle to helping you determine how good your kidney function is. But this is important. Doctors, internists, pediatricians talk about staging of chronic kidney disease based on 5 stages, which is directly related to your GFR. Stage 1, you have some reason to have kidney troubles. Maybe you have only one kidney. Maybe you've had a lot of kidney infections, but your GFR is normal. Stage 2, your GFR is mildly reduced. Stage 3, your GFR is moderately reduced. Stage 4, severely reduced. And stage 5, GFR is less than 15, or you're on dialysis. And each of these stages have different management things that need to be done. Okay, let's take an example of this teenager. He's 16 years old. He used to be very adherent with all his medications. And when he turned 13, he started becoming a teenager. Mom started finding pills in his pockets. And when he went to summer kidney camp, Mom cleaned his room and found hundreds of pills under his bed. We look at his kidney function, we look at the serum creatinine, and this is from 2010 to 2014. And here his creatinine had been sort of running in the 1.5, 1.8 range. But then in 2012, it started going up fast. And then, oh my God, it went up from 3 to 4 in just a few months. And the parents freaking out saying, oh my, something's wrong. You need to biopsy the kidney. He's having a rejection. What's happening here? Because this is crazy. When you actually look at it from the GFR perspective, that was a straight line. And his deterioration of kidney function had been going on unchecked since that episode of rejection was found. So why is it that the creatinine goes up much faster when the GFR is going down here? It's because unfortunately the relation of creatinine and GFR is not aligned. It would be lovely if if your GFR fell, your creatinine would get up and go up. It was a straight line. But that's not the way it is. This is the way it is. Your GFR can fall quite significantly at first, and your creatinine barely changes. But at the last little bits of GFR, when you're at 50% or 25% GFR, that's when your creatinine really starts shooting up. So parents get lulled into a false sense of security because as their child's kidney function is deteriorating, or as their kidney function is deteriorating, it takes a long time to go from, say, creatinine of 1 to creatinine of 2. But going from 2 to 3 happened much more quickly. 3 to 4 happened even faster, and 4 to 5, and talking about dialysis, was in the blink of an eye. But that is a straight line. These are the same data points turned into GFR. So this is why it's so important that you understand your child's GFR, because the rate of loss of GFR for most people is usually constant. And so the need for dialysis or transplant can be predicted. So you can plot that line going forward and say they're going to be at about 10 or 15% GFR at this time. So we need to start talking about long-term plans. Patients lose renal function at a relatively constant rate, which is specific for that person. So I've got a bunch of different graphs from patients that I've followed over the years. And this is a GFR for over about 10 years, showing a gradual deterioration. But this is another patient's and another patient showing faster deterioration. This was a patient who was doing really well until there was an episode of rejection, and then their GFR fell fairly quickly. This is someone who we were following along through all sorts of crises, but their kidney kept bouncing back. But just because you have a low GFR doesn't mean you're doomed to need a kidney transplant. We have some people who have low GFRs and they just hang in there for years and years and years. So understanding your GFR and change is really important. But the GFR is only part of the story. This is a patient I looked after. He was a teenager. He was smart and stubborn and hardworking, and you can see his GFR falling and falling until it was about between 10 and 15. And here we said, okay, time to start dialysis. He absolutely refused. He said, there's no way I'm starting dialysis, and you can't hold a teenager down. So for the next year, his GFR looked the same. What happened? Why did his GFR not change? It's because other things were going on. During that year, when his GFR didn't seem to change, he lost 10 kilos of muscle. He wasn't eating well. He wasn't thriving. He deteriorated from being a varsity athlete to being unable to even go for a walk and exercise. And his grades fell from A's to D's. So the GFR didn't change, but what was happening was he was losing muscle. So the creatinine and calculated GFR must be interpreted based on the patient's weight, their nutrition, their muscle mass, how healthy they are, their activity, their grades. We put them all together to get a global assessment of that patient. So say it ends up that you want to determine your child's GFR. How do you do it? Well, the easiest way is using a website. And if you Google Pediatric GFR calculator, or the National Kidney Foundation, you can plug in your child's creatinine and height and sex. And if your local doctors also check it, the cystatin C. Using the cystatin C makes the equations more accurate. You hit the calculate button and it'll give you an idea roughly what your current GFR is, and you can track it over time. Now, say it's appearing that your kidney function is deteriorating and at some time in the future, you're going to need a kidney transplant or dialysis. What are the things that you need to know about your child or yourself? Well, first, adults wait a lot longer than children for kidney transplants. So this is a graph of the adults that were put on the waiting list in 2016. 3 years later, look at the green line here, only 20% had developed deceased donor kidney transplants or had gotten a kidney transplant, unless a living donor. A lot had died or had taken off the kidney transplant, taken off the list because they were too sick. Compare that to kids. Kids and this who started in 2016, 3 years later, more than half of them had received a deceased donor kidney transplant, as opposed to only 20% of adults, and more had living donors. So kids are given preference on the waiting list for kidney transplant, but that's only if they're on their list before their 18th birthday. If they're identified with kidney troubles and they're put on the list the day after their 18th birthday, it's very different. And then the criteria for them are adult criteria, and they'll wait a lot longer. So how do you get on the wait list? Well, your waiting time starts at either the first day of chronic dialysis. So if you start dialysis, that's your first day of waiting. Or after you're evaluated and then accepted to the kidney transplant list by a kidney transplant center. The rules for adults are that your GFR has to be 20 or less to be put on the list if you're an adult. But children have more flexibility because they're more complicated than adults are. And so your kidney specialists have the opportunity to put them on the waiting list well before a GFR of 20, so they can start getting waiting time or get on the list before their 18th birthday. Because if you get on the list before your 18th birthday, you're still considered a child even if you're 19 or 20 when you actually need that kidney. So you get the benefit of shorter waiting times if possible. So if your child's GFR is falling, you should talk to your doctor about when to be referred for a kidney transplant evaluation. Okay, living donor kidney transplant. Um, One of the things I always tease the patients that I look after is always be nice to your brothers and sisters, because you never know when you might need one of their kidneys. And this is really important. However, what do you do to keep your kidneys lasting longer? I've given you a talk about the fact that whether you're a heart transplant or a liver transplant or a lupus or kidney transplant patient, your kidney is potentially in trouble and you may need a kidney transplant at some time in your life. And for example, for pediatric kidney transplant patients, the average pediatric kidney lasts 10 to 15 years, which means when I look at a 5-year-old, I'm telling the family, your child's going to need more than one of these because the average gets them 10 or 15 years if it's a deceased donor, maybe 15, 20 if it's living. So they're going to need at least one more in their lifetime. So how can you make that kidney last as long as possible? Well, some of these things are fate. Some of these things are things you can do something about, like obesity. For example, if this is the reaction of your nurse or doctor to your blood pressure, you got to deal with that. But an important thing that we're finding out is your diet is a huge factor. And in this image of the DASH diet, and very similar to the Mediterranean diet or Canada's food guide, half of the plate is brightly colored vegetables. A quarter are starches. Potatoes are not a vegetable, they're a starch, and especially French fries. And a quarter are protein, some of which is meat, but a lot is beans, peas, legumes, stuff like that. And there's hard data coming out that shows this. This is a study where they were using the DASH diet, which is dietary approach to stop hypertension. It's basically a diet which emphasizes lean meat, greens, red vegetables, limiting milk intake. And they broke down patients who had had a kidney transplant to how much of a DASH diet did they follow. And here at this end, it's the people that are mostly carnivores, burgers day and night. And at this end are the people that are mostly vegetarians. But if you look at their risk of kidney failure, now these are kidney transplant patients, the risk of losing that transplant was twice the average in the people that were mostly carnivorous and half the average in people that were mostly vegetarian. Same thing for all-cause mortality. Twice the chance of dying if you were mostly a carnivore, and half the chance of the average population of dying if you were mostly vegetarian. That tells us something. And there are other lines of evidence that are confirming this. Now, people talk about the acid load of food. Now, this is a study of people who had chronic kidney disease, and it broke down into the kind of food they eat and how quickly they went into kidney failure. And the people with the highest acid load went into kidney failure faster than the people that had the lowest acid load. Well, what's an acid load? It's not what you think. This is a graphic that talks about the acid load of various kinds of food. The most acid producing foods, which are the worst for your kidney and your health, are hard processed cheeses, egg yolks, and meat. And that's not just red meat. The kidneys don't care. Meat, chicken, turkey, fish, all the same. Meat, poultry, fish are acid load. One of the best things you can eat is most fruits and vegetables because they actually suck up acid. They produce base. So they're healthier for your kidney function. So if you're making decisions for your child, trying to train them or yourself, if you know your kidneys are at risk, just think of this picture. The kidneys love brightly colored fruits and vegetables, and that will change your life in some ways. Okay, last couple of minutes. One other thing I wanted to talk about. When you've got an old car that you love to drive and you're pushing it too hard, it generates a lot of smoke. For damaged kidneys, protein in the urine is the same as smoke coming out of the tailpipe of your car. If your kidneys are generating proteinuria, that's a sign they're in trouble. What happens is when the filters of the kidney are working too hard, they start leaking, and that protein leak is a sign the filters are under trouble. What you can do is with your doctor, there are medications that can actually delay the progress of kidney failure. And ACE inhibitors, which are like captopril, losartan, lisinopril, enalapril, captopril, or angiotensin II receptor blockers like losartan or other sartans. They reduce the workload of the glomeruli, so those glomeruli last longer. And actually, when you start these medicines, we want to see your creatinine go up a little bit, because what's happening when your kidneys are damaged, the filters you do have left are working their tails off, and they are becoming overloaded. They are actually overworking and becoming burned out. So if this is a GFR graph showing what would happen to a patient with prediction of end-stage renal disease at some time in the future, you start them on these protein-reducing drugs like an ACE or an ARB or SGLT2 inhibitors, which are the new kids on the block. You get your GFR worse just a little bit by 5 or 10%, but the slope flattens out. This is like you've got an overworked, burned out doctor or overworked, burned out teacher. And here you're telling them, relax, take it easy, take some vacations, take some mental health days, do some wellness. Basically, you're telling that overworked professional, don't work quite so hard. And sure, it looks like their productivity's gone down a bit, but they can function a lot longer before burning out, and they can last for years longer. And that's what we find with kidney disease. You start people with proteinuria on these drugs, and that extends the life of their kidneys. So say you have a patient whose GFR deterioration is predictable, that they're going to be on dialysis or need a kidney transplant in 7 years. If at about age 4 years before that, you start introducing protein sparing medications, you put them on more of a vegetarian diet, less carnivore, get them to lose some weight, get them to exercise, stop smoking. You can extend the life of those kidneys for years, keeping them off dialysis or transplant. And the earlier you identify potential for kidney risk and you make positive lifestyle changes, the more years dialysis free you're going to have. So these are some recommendations to help you keep your kidney good. But one other thing, it's important to be honest with your care team. I've had patients that say, oh, I take my medications, or oh, I exercise, and they're only fooling themselves. So don't do what this person's doing, walking their dog. Actually be open and honest with your healthcare providers. Tell them what you're really doing, and we can give you some good advice. And that's the end. Thank you.
Thank you so much, Dr. Grimm. I am 10 years into this, and I have to tell you, another kidney transplant parent was texting me in the middle of your thing going, did you know all this? I didn't know all this. So this is very informative. And I think one of our top questions was that for as non-kidney transplant recipients, what can we do as parents to protect kidneys? And you answered that in a really interesting way, especially with the diet and exercise are always very important, but the suggestion about ACE inhibitors, how would you suggest patients talk to their doctors about the possibility of ACE inhibitors?
Well, I think that when you have an open discussion about where the kidney function is and you realize that that's a big deal, one of the things that we've learned is many doctors are reluctant to really talk about potential bad things. If I'm your heart transplant doctor and I've known you for years and I'm seeing some deterioration of the kidney function, I don't want you to worry. I kind of want you to downplay it. I say, oh yeah, your kidneys are a little bit weak or they're not doing so good. They've done surveys of kidney patients, and kidney patients actually want numbers. They don't want to be told by the doctor, oh, it's a little bit bad or it's a little bit rejection. They want to know percentages. They want numbers. They want prediction. And so having an open dialogue saying, doc, I'd rather know, like, what is the situation of my child's kidney? What percent kidney function, what GFR? Are there risk factors? Like if there's protein in the urine, I'd like to know about that. And getting an open dialogue, because I want my kid to do well for 5 years or 10 years or 20 years. And so that's an important dialogue. If there's protein in the urine, it then opens the door to discussing ACE inhibitors, ARBs, things like that. And if there's no protein in the urine, well, you still can look at the exercise and activities and lifestyle issues, because as a parent, we've still got some control over our kids, so we can encourage them to like those green and red leafy things. And even in my old age, look, I love a steak or a burger, but I'm only getting a single Big Mac, not a triple Big Mac, just because of those things. And I'll get a side of vegetables.
Thank you. We had a question about some of those dietary and ARB preventions. Do they help children with genetic disorders like NHPH?
Sure. The studies of adults with CKD were all comers. So when you have people of various causes for kidney disease, when they've lost some of the nephrons and the leftover nephrons are overworking, that's a common pathway. So whether you have NPHS1 or nephronophthisis, or maybe you had kidney cancer and your left kidney was removed and part of your right kidneys, you're just dealing with like a quarter of your normal kidney function. That's a normal kidney. All of those things lead to the filters you have left overworking. Or maybe you were just born with small kidneys, but they're perfectly normal, but you're a big guy. All those things cause the filters to overwork, and all those maneuvers can be beneficial. Yep.
Um, I'm looking at a quick question about how is adult transplant UNIS listing affected if an adult received a transplant as a pediatric child? So let's say that they had a heart transplant as a child, but now as a 18-and-a-half-year-old, they may need a kidney transplant.
Right.
Is the UNOS listing affected by that?
So you are looked at, kidney is separate. So if you just need a kidney transplant and you come to them at 18 and a half, you're considered an adult. And the waiting time for adult kidney transplants, the longer waiting time applies. If you say you have a heart transplant and your heart is failing, and they're thinking, your heart's failing, so we're looking at retransplanting you. And you also need a kidney because over the years, your kidneys become banged up. What happens then is you get considered for a combined organ transplant where the kidney is the primary organ. So they find you a heart. So, the heart's the primary organ. They find you a heart and the kidney comes along with it. So the same waiting times, like, 2 or 3 years for kids, 8 or 10 years for adults, that doesn't count. Because whenever you get your heart, the kidney that came with it in that donor will come with you in some situations. They also have more complicated issues for, say, your heart transplant happens, but you're too sick for a kidney transplant, or they think your kidneys are going to recover. If you actually are developing kidney failure, either after your liver transplant or your heart transplant within a certain period of time, there's rescue things that are potential. So it gets complicated, but so you need to sort of sort out your own specific situation. And I know what I said was quite complicated, but the bottom line is that if you are approaching kidney failure or considering kidney failure and your child's approaching their 18th birthday, that's something that you should have a discussion with your doctors before their 18th birthday, because that 18th birthday is a hard stop. And if it turns out that you're found to have kidney failure or brought into the kidney transplant list just a couple of days after your 18th birthday, there's no do-overs. There's a very clear government rules.
Great. All right. I'm sorry to cut you off right now, but we are at time at 1 o'clock. I would like to thank the speakers and the audience, for everyone, for your time. We've had some great questions. If your question was not answered, it will be provided to our speakers, and they'll get an answer to you, and it'll be emailed out later. I think that's it. So, hey, go find another great session. Thank you so much, everyone. I really appreciated all the questions and all the information and your time. And thank you so much. This was great.